ask. So, and I have Dr. Ayman Surak. He's assistant professor at the University of Alberta. He's with me in this group. We're going to assess or to learn how to assess assessment of the diaphragm and assessment of the upper airway. Just I'm going to go over our guidelines in our unit, how we apply lung ultrasound in our unit for diagnostic applications and also to predict responsiveness to different interventions. So what I'm showing you on the screen now, it is our algorithm, and we are using ultrasound on a daily basis, and we have all of the in-house staff trained in ultrasound, nurse practitioners. Also, we have our respiratory therapists. They are trained, so we have 24/7 coverage for ultrasound. Ultrasound can be used for assessment also of the diaphragm and the upper airway. That will be the focus of my presentation. But typically, lung ultrasound as a lung can be used to differentiate RDS from TTN, much more sensitive than X-rays, meconium aspiration, pneumothorax, pneumonia, pleural effusion, pulmonary edema, congenital diaphragmatic hernia. And it is nice to score the lung. One of the stations will teach you how to score the lung. Typically, you have score up to 18. Anything less than 6 or 0 to 5 is mild, or it could be normal lung transition, for example, for infant who just born. And if we have infant on respiratory support and the lung ultrasound score is less than 6, we may think to wean the support or consider the next step could be fit for extubation if he's intubated. Together with other clinical parameters, we are not taking decision based on the lung ultrasound only. It is integrated to the clinical assessment and other markers of hypoxemia. Moderate lung is 6 to 10. It means that you may need to stay, or you may need to keep the current parameters without weaning at least, or you may escalate if the infant is showing worsening hypoxemia. Severe, more than 10 or 11 to 18 means that you need to escalate, you need to recruit the lung. Lung is almost collapsed. Lung ultrasound is proven to be sensitive assessment tool of any lung disease or most of the lung diseases. It can be considered as a first radiological modality if infant is stable on CPAP. The problem if you have someone sick on mechanical ventilation, if you don't know how to assess the ATT position, that might be the limitation for you to assess everything on infant who is sick. But eventually, you may get experience on how to assess the lung by the upper airway as well. Okay, so let us move on. Now I need someone to suggest how to score this lung. So you have the right side and left side. You don't have all of the zones, but just the right side and left side. This infant was 33 weeker, just a few hours old on CPAP, and FiO2 is 28% and is increasing. So what do you think? Anyone can participate?
I think the right side looks like it's score 2+ or maybe 3, and even left side score 3.
3. Actually, both sides are like more homogeneous than 3, because I can see air bronchogram, interrupted pleura, discontinuous pleura on both sides. Here you can just see the part of the heart shadow, but lung is really atelectatic subpleural atelectasis with air bronchogram. So 3 on both sides. So we need to assess the lung pattern. Homogeneous on both sides is consistent with RDS, infant who just born, and consistent with RDS, homogeneity, lung score. So score of 3 in all of the zones will give score of 18 total. That's very high. And there is no pneumothorax, no effusion. You need to keep that in mind to rule out both. Evidence of worsening hypoxemia. You need to integrate lung ultrasound. Don't jump and consider intervention based on the lung ultrasound only. So the infant was requiring oxygen and it is increasing. And we are using histograms, oxygen histograms. If you are not using that, it is very helpful for assessment of hypoxemia. Oxygen histograms on daily basis. Saturation FiO2 ratio is also important, and mean airway pressure. At the end, what could be your intervention for this infant? No change, give surfactant on increased CPAP. What you usually do in your unit in this scenario?
Yes, sir. What is the age of the infant? I'm
Surfactant.
sorry.
Yeah, 33 weeker, just 3 hours old on CPAP of 7.
Ah, okay. Well, then that would be surfactant, I guess.
Okay, very good. Any other suggestion? Increase CPAP?
Sorry, I didn't hear that, but I would change it to BiPAP if available. If not, the in and out surfactant, maybe Lisa.
Yeah. So in our unit, we prefer to use like surfactant once you have infant on CPAP of 7 after birth. Score more than 8 is proven to be sensitive in randomized control trial for premature infants less than 34 weeker. We are using FI2 more than 25% and increasing CPAP more than 8, 9 or higher to give surfactant. It can be by MIST if the infant is premature less than 33 or by INSURE if the infant is more than 33. So that's our protocol. I don't claim that this protocol should be followed everywhere, but we have seen some babies, if you increase CPAP beyond 7, they might develop pneumothorax. If you wait more time, if the lung ultrasound score is high. Or you might prolong the duration being on CPAP. So they may stay on CPAP for more than expected and longer hospital stay. We can also use lung ultrasound for recruiting the lung. So if the lung is totally de-recruited, it will be gray or hepatization of the lung, no aeration at all. Some aeration will see air bronchogram, like our example. More aeration, you will see discontinuous pleura with less air bronchogram. And then you will see the pleura more continuous with P lines. And when you started to see some A lines, you may add the opening pressure now. So we are using to escalate the PEEP up lung recruitment and doing ultrasound in between. So that's another modality of using ultrasound. Let us now speak about our presentation or our session. We are now talking about a diaphragmatic excursion. If you look at this X-ray, you might be convinced that there is diaphragmatic paralysis or eventuation of the diaphragm because you have more than 2 spaces between the left and right side or copula. This infant, term infant, 4.8 kilogram HIE with the humeral fracture. So we have already evidence of birth trauma. Then it is very easier than sending the baby to fluoroscopy. You check the diaphragm on the right side and use the liver as the interface. And I will show you how to do that on the ultrasound machine. You apply M mode and you will see just a flat line. There is no any movement. You can detect that also by 2D. On the other hand, that's the left side with the same baby. Can you see the diaphragm even by 2D is moving up and down? And with the excursion that we can assess, we can freeze the frame and assess the height of this excursion, and we can measure it. It is acceptable more than 0.5 centimeter at the minimum in premature infant and close to 1 centimeter in term infant. Make sense? So if you have less than 0.5 or flat, it means you have weakness of the diaphragm or paralysis. And the infant should be breathing regular, either mechanical ventilation, not crying, should be quiet and breathing regular rate.
Sorry, did you say less than 0.5 centimeters?
Yeah, it's low. Yeah, it should be more than 0.5 centimeter excursion. In premature infant, yeah, less than 0.5 is weak. And again, you have to measure it different time and measure it not just one measurement. You have to, in one frame, 3 measurement and measure it in the 3 different times. Yeah, don't just measure it one time and that's it.
And what is that liver interface? What you suggested is that where that alignment should be.
I will show you that on the machine. Just give me, like, let me finish the description, and then I will take you to the machine, and I'll show you how to do that on the machine.
Thank you.
Okay. Yeah. So let us move to the next. How to assess the upper airway. Upper airway is not very difficult if you start to practice that. Upper airway, you are evaluating at multiple levels. The most significant or the most important levels at the thyroid cartilage level, you cannot reach by ultrasound the epiglottis. That's impossible to see the epiglottic level or edema. You can see the thyroid cartilage and the cricoid cartilage and the tracheal rings, and I will show you that in the ultrasound. If you look at the, that's exactly the picture that you will see by ultrasound. You will see inverted V with the vocal cord or the membrane, and when the vocal cord open, you will see opened inverted V or separated. Here by ultrasound, you have the thyroid cartilage. It is hypoechoic, and medial to the thyroid cartilage, you will see two right and left vocal cord membranes, and they are co-opted in the middle, means there is no movement now. But I need to see that as a video to evaluate the movement. So they are closed. Now they are open. So you have widely open inverted V. So you have again the thyroid cartilage, and the medial to the thyroid cartilage, you have the vocal cord membranes. And the echogenic line here, it is the interface between the air and the vocal cord. You will see it echogenic. And then if you move down a little bit, you will see the cricoid cartilage. Cricoid cartilage is different from thyroid. It is more circle, not pyramidal or not like V-shaped like thyroid. It is half circle, again hypoechoic, and you can see the reverberation of the air below that. It means you have air inside. How to assess the unilateral paralysis? When you apply the probe over the thyroid cartilage and the vocal cord, you will see the movement just to one side, as you can see, not in this image, and deviated from the midline. And then if you have bilateral weakness, can you see clear V line or inverted V here? No, they are almost co-opted, and the infant is crying, moving and crying, and there is no significant separation. This infant was premature, CPAP dependent until almost 40 weeks corrected, born at 22 weeks, and we couldn't actually wean off CPAP because of the vocal cord paralysis or weakness. And the reason was subclinical. Only we detected the reason when we assessed the vocal cord after removing CPAP by ultrasound. This infant might need CPAP for a very long time. Now you can see unilateral movement. So if you put a midline, you can see deviation. The right side is pulling the left side. Left side is paralytic, and there is deviation just to one side of the vocal cord. Is it easy to detect, like unilateral movement of the vocal cord? For sure, you need to see many cases to be expert in evaluating that. Now I will show you on the endoscopy. In this example here, I will let you listen to the conversation and let me know what's your impression. This infant, by the way, was a term infant admitted because of significant stridor, but not in respiratory support.
I would love to see those cords, but not getting a good view. I wanted to, but you know what? It's just too much. It's just too much edema, and he's got quite a bit of posterior supraglottic edema as well.
Okay, so did you realize what's the issue? So the ENT physician could not see the vocal cords because of too much edema of the vocal cord. So can she just see only very significant epiglottic edema? No vocal cords can be seen. With ultrasound, I'll show you exactly just 5 minutes after the ENT physician left, or I just showed him that we can see the vocal cords co-optation movement easily by ultrasound. Is it good movement or weakness? Anyone can comment? Is it good vocal cord movement?
Looks like a palsy on the left side.
Yeah, the infant is moving to the left side, but like both sides are moving. The infant is crying, very good movement, and if you freeze, you can see wide opening now.
At least for me, the videos show quite choppy, so you see like every 10th frame probably, so it's a little bit tricky. But
Yeah,
if
because the infant was
you
crying
open-
and moving. That was like the limitation. But if you freeze the image, I can see widely opened, and like the both sides is almost the same size. I'll show it to you again. When the infant is crying, might be difficult to see because it's not a regular movement. Infant is crying irregularly, but it is very good movement and is not the same like one unilateral paralysis. Anyway, you need to practice more cases. It's not difficult to put the probe, linear probe. I will show you how to do that in the simulator. What about the insertion of the ET tube? Yeah, move to the next. Assessment of the ET tube, you have 3 different approaches to assess the ET tube insertion. The easiest way that I advise you to start with to assess the lung sliding and also the excursion of the diaphragm. If you have someone who is flat, intubated, and then someone is bagging, you need just to assess a sliding on both sides to be sure that the ET tube is in and that the expansion is bilaterally equal. Direct visualization of the tube, you need a little bit more experience, and then ET tube tip position, you need much more experience because you need to know how to assess the aortic arch. So you need experience with echo. So these are the 3 approaches, and I will show you how to do the 3 approaches one by one. So now there is a person here, the probe over the neck, and someone inserting ET tube. You will not see the ET tube, but you will see some artifacts of air moving inside. And if the ET tube is in the esophagus, it is easier to detect that by ultrasound. If you cannot see the esophagus, so the esophagus is normally collapsed, cannot be seen. If the ET tube is in the esophagus, you will see 2 tubes, 2 air shadows, because the ET tube is distending the esophagus, and also the trachea is already distended by trachea rings. So you will see side by side 2 distended air shadows. If the ET tube is in the trachea, you will see only 1 shadow, like the previous one here. The pulsating vessel just beside the trachea, it is a carotid artery, and more lateral you have the jugular vein. So if the trachea in the middle, carotid artery in both sides pulsating, and then more lateral you have the jugular vein. So you have a polyp sign because the air artifact, esophagus not seen. So if you have the ET tube in the esophagus, you will see definitely 2 airways. If the esophagus is not distended, and even slightly distended by orogastric tube, it should be collapsed over the tube. You'll not see the double shadows of the air. ET tube to position, you need more experience because you need to see the aortic arch at the same time, which is just arching above the carina. A carina cannot be seen because it's just full of air. So 1 centimeter to 2 centimeters is acceptable distance. How to do that? You need to use a probe, not the linear probe. You need to use the echo probe or the microconvex probe. And exactly the same as you are evaluating the aortic arch by echo. You need to use the suprasternal window and apply the probe over the aortic arch, and then try to manipulate until you bring the ET tube in the position, as you can see here. So we have the aortic arch with the branches, and this is the ET tube shadow. If the ET tube is very deep to the carina, you will see the ET tube shadow crossing deeply to the crossing the aortic arch, and you need to adjust that. Ask the bedside nurse or the RT to adjust the ET tube. So what is a normal acceptable distance? It is between 1 centimeter to 2 centimeter. So if the infant is premature, less than 1 kilogram, 1 centimeter is enough, and 0.5 above or below is acceptable. 1 to 2 kilogram, between 1 to 2 centimeter. More than 2 kilogram is more than 2 centimeter, more than 2, like around 2 centimeters. 0.5 centimeter below or above is acceptable. So it is like very easy. 1 to 1, 2 to 2 kilogram, 0.5 above, 0.5 below is acceptable. Again, you need to adjust a little bit. You may need to move the probe more short axis to the aorta to be able to see the ET tube. If you cannot see the ET tube at all in the image, it means the ET tube is high at the level of the epiglottis. You need to push it until you're able to see it. Again, this technique is the most difficult one, and you need to practice a lot. You need to have some experience to visualize the aorta by echo.
Sorry, you're suggesting that it's the distance you suggested, 1 to 2 centimeters, or more than half centimeter. Is it the distance from the tip of the ET tube, or is it from the carina to the aortic arch?
No, it is from the aortic arch, either the tip or the middle of the aortic arch to the tip of the ET tube. You cannot see the carina. We can just see the aortic arch. So you have here the distance almost 1 centimeter between the ET tube tip and the aortic arch.
Okay.
So it is between 1 to 2. I'm just showing in this video how to apply the probe. Yeah, let us now move to the simulator, because you will see more details. You can see the simulator now, the ultrasound machine.
Yes.
Sir.
Okay, let me just calibrate the probe, and let us start with the first case. I will now just go over the most like the easy way to assess a child who is intubated. So we have this child, he's smiling, but he's actually intubated, and we are going to evaluate now if the ET tube is in a good position or not, without even doing anything over the neck. What we can do, if the infant is collapsed, he should not breathe by himself or with the RSI, like receive the muscle relaxant, and he's not breathing, only the movement. You can detect the movement of the bagging. Someone is bagging, you can detect the movement of the diaphragm. So now I'm applying the probe either over the anterior axillary line or the mid axillary line, just below the costal margin. Now you can see the lever, the diaphragm is moving, and the lung, the basal part of the lung. Now someone is applying bagging to the chest. The diaphragm is moving in both directions. It means the ET tube is in, because if the ET tube is the esophagus, you should not see any movement. That's on the right side. But the ET tube could be deep, only impact on the right side. I have to also assess the left side. The left side is a little bit tricky and not as easy as the right side, because the liver is big. You need to use on the left side the spleen as interface. So let me move the probe to the other side, and let me show you that. So can you see the probe now with the interface at the posterior axillary line, not mid, because the spleen is more posterior. You need to adjust. Yes, now I can see the movement of the diaphragm, or at least movement of the lung, infant's breathing. So you can see now the spleen, and you can see the shadow, air shadow of the lung. If the ET tube is in the right side, you will not see any movement on the left side. So I can see the lung movement and the diaphragm moving with the, like just above the spleen, with the same synchronized with the same movement of the someone who is bagging. So now I'm sure that the tube is in. That's like the easy way to assess intubation in after or during resuscitation.
Can you repeat that on the left side, please, once more? The one you just shown, please. Thank you.
Yeah, I will show you that, but let me also show you another easy way. If you put the probe over the chest, just over the anterior part of the lung, you will see the sliding. The only limitation of that, if there is pneumothorax, you will not see the sliding if there is pneumothorax. But can you see sliding clear? breathing with the sliding on the right side and also left side. Maybe more clear here. Can you see the sliding of the lung? Yes?
Yes.
Okay. Yeah, so if you have a sliding in both lungs and synchronized with the bagging, it means the tube is in. And the tube probably above the carina, because you can see the left side sliding is very good. Now let me show you again the left side or the left diaphragm. You need to use the convex probe for the diaphragm. So apply the probe more posterior to the posterior axillary line, because the spleen is more posterior compared to the liver. I think you know that from the anatomy. And you can see now the movement of the lung probably is more clear than the diaphragm itself. Can see the movement, the air artifacts moving of the left lung. Just trying to get the diaphragm more clear, because like the aeration is very good. That's why you see the artifact moving. But I can see very easily. You don't have to stay a long time, because this infant's under resuscitation, and you need to continue connect mechanical ventilation. You need to do that in 1 minute. It should not be more than 2 minutes. So this is the easy way. Let me show you now the little bit more tricky way of assessment of the tube. And before that, we need to get an idea about the anatomy of the upper airway. So for this child, I'm now evaluating the anatomy of the upper airway. In the upper airway, I'm using a linear probe, because the linear probe is high frequency. You can use a microconvex if you have a high frequency one, but the preferred probe is a linear probe, applied just above the upper part of the neck, just below the chin of the neck, and to be able to see the thyroid cartilage. The thyroid cartilage is more pyramidal compared to the cricoid cartilage. I will show you the cricoid cartilage. You can see incredible details of the anatomy here. Very nice assessment of the anatomy. Just trying to get the vocal cord clear to you. Be sure that you adjust again. So it is very dark, you cannot see anything clear. And here it's very bright. You have to make the gain is adjustable. A nice contrasty image, and also the depth. That's very deep, and this very superficial. It should be in between. So you need to know how to adjust the depth and the gain for any image, and you will get that also from another station. So now I'm going to assess, maybe decrease again a little bit, the upper airway at the level of the thyroid cartilage. You can see the thyroid cartilage, hypoechoic and nice. Outside the thyroid cartilage, you have the neck muscles, and if you move, you can see also the vocal cords with some fluid air interface, because you have also some saliva secretions over the vocal cords. And then if you move down, you will see what's next to the thyroid cartilage. Who can help me? So what I can see now, what type of cartilage? What's this cartilage?
Cricoid.
Cricoid.
Cricoid, perfect. The cricoid is more circle, and you have the air artifacts again below. You cannot see any vocal cords. And what's lateral to the cricoid cartilage? Here.
Mandible.
No, you cannot see the bone mandible. That's actually the thyroid gland.
Oh,
And
yes.
yeah, thyroid gland, what's lateral to the thyroid gland? What's this circle here, which is pulsating?
Carotid artery.
The carotid artery. Very good, carotid artery, and it should be on both sides. And then if I move more longitudinal, just move the probe, be sure that the index mark to the right side of the patient. So you know that you have here the right side, because you have the index mark, you have the right side and the left side. You have to be oriented about the position of the probe, because you may have unilateral paralysis and you may need to know is it right or left. And then move the probe more longitudinal. Don't miss yourself about the air artifacts as ET tube. You can see air lines here. That's not the ET tube. They're just air artifacts. Superficially, you see hypoechoic rings. These are the tracheal rings. And this is the cut section of the cricoid cartilage. And you have here the thin layer of the muscle, superficial muscle of the neck, and the skin layers and subcutaneous tissue. And then move again more cross section to see the details. Any question about the anatomy of the upper airway? So you can see incredible details of the anatomy here. You have the vocal cords as a membrane, and you have here like some artifacts due to the fluid and the thyroid cartilage. Let us see.
I know this is simulator, but in a real life, with that a flat probe, can we see the vocal cord movements?
Yes.
In a near?
Yeah, as I showed you the video. The video is actually from the real case, as I showed you already. Okay. And this simulator is actually also real, based on the real images. So we have like this infant who is crying. You can see the vocal cords moving. Yeah. So for sure, you will see if the infant is crying or infant is breathing, you should see the vocal cord moving. But if the infant is intubated, you should not see any movement, because the ET tube will limit the movement of the vocal cord. We'll see just air artifacts in the middle. So let us see someone intubated. How the upper airway looks like for someone intubated. So this actually guy was intubated, and now I'm showing you first the cricoid cartilage. Now you can realize the difference. In adult is less clear. In neonate or in children, you will see the details and the anatomy, because more superficial, more clear compared to adult. So here you can see the airway, and you have a double line here. The double line here is the upper layer or anterior wall of the ET tube. And then if I move the probe more long axis, you will see the upper layer of the ET tube more straight. Then you are sure that the ET tube inside, that's not the entire ET tube, just the anterior wall of the ET tube. Is it clear? Then you are sure that the ET tube in the upper airway, but you can see the tip. The tip, you need to do the technique that I showed you in the slides. You need to visualize the aortic arch, or the alternative, you are not expert enough, you need to check the expansion of the lung or the lung sliding in both sides, or diaphragmatic excursion. So in this guy here, you can also assess a little bit lower level. That's at the lower level. The lowest that I can see in the neck, I can see still the ET tube inside. And then when I move in cross section, should be on the right side here. How I am sure if I cannot see the ET tube clear? That's another sign. What's the other sign that I already discussed? But now I'm sure that
the bullet sign.
Exactly, yes. So like the ET tube is not in the esophagus. So we cannot see the two air distinction or two air spaces, only one space. If you have the ET tube in the esophagus, you will not see. You will see as two trachea instead of one trachea. You'll see the double trachea sign. So if you cannot see, because it could be a lot of air and just artifact might not be visualized easily. So there is multiple ways to be sure that the ET tube is in the right position. And you may do that without need for X-ray at all. And now what the other sign? You just repeat that again. Can you see sliding or not?
Yeah.
On both sides.
Yes.
Yeah, I think that's very clear. You can see the B lines moving from side to side. So while someone is begging, you can see with begging synchronized with that, the lung is sliding on both sides. And also you can check the lateral side of the lung as well. For someone who is sick, you can realize that you have the basal part of the lung is more atelectatic or more alveolar edema. Okay, very good. Let us now move to another. Any question about airway? Because I'll give you another challenging case. Any question?
So Yasser, how do we make sure for the distinction between the air artifact and the ET tube wall, as you were mentioning, that they can look similar if you are not sure what you are looking at?
Yeah, if you are not sure, use another alternative way. If you cannot see the esophagus descended with air, so there is no double shadow of air, it means that you are in the trachea. That's the easiest way.
Okay.
Yeah, so first, if you intubate and put the probe while someone is intubating, if you see that there is another trachea, it is not a trachea for sure, it is esophagus distended with air shadow, appear and was not present before, it means you are now have the tube in the esophagus. You have to take it out right away and then ask him to re-intubate again. If the tube is in and you can see only one shadow, it means the trachea is in. Not necessarily to see the ET tube shadow or not. Okay? And it is a bullet sign. You can see the bullet.
At that point, where should we put the probe on? Because it depends on the length.
Right. Yeah. So the probe, it's better to use a linear probe. It is the easy one. You can put it. It's better to put it on over the tracheal ring or cricoid cartilage. So it's better to be below the thyroid cartilage. Tracheal ring. That's why I said it's better to have it as a low, the low level as low as you can.
Will that expand esophagus if it is much down below in esophagus? If you are looking at the ET tube above the tip.
Yeah, like if the tube is in the esophagus, if you put the probe even in the lower level or upper level, you should see the double shadow. You'll even if it is lower level, you will see that because the esophagus is bathing side by side, you're slightly behind the trachea, so you will see just on the side and behind another shadow. And if you are struggling sometimes, put the probe on the side. Just move the probe to the side a little bit, and then you can move from side to side. And to be sure that you only have one air shadow can be seen. Sometimes it might be difficult, tricky, in very rare situation to be seen from only the anterior. Just move the probe slightly lateral. And this should not take more than just less than 1 minute. That should be less than 1 minute. Just put the probe and move. You will see just one shadow. You may or may not see the ET tube inside, and you are in. And then to confirm, check the lung expansion by lung, both sides, while someone's begging. And also to check the lung, you have another value. What's the other value? Can someone tell me what could be the other value of assessment of the lung, someone who's crashing? Now you rule out pneumothorax, you rule out pleural effusion, and you can get an idea if the lung is not inflated well. You ask the person who's applying pressure to apply more pressure, because the lung is still atelectatic. So please apply more PEEP or give more PIP to distend the lung. So you have more than one value for assessment of the lung expansion while or right after intubation. Any question? Then I will give you another case scenario. Okay, so let me now show you another case scenario. And I'll ask you, what's your interpretation? Okay, look at the ultrasound. image. Maybe enlarge it. So who can jump and let me know what's your assessment of this line? Yeah, I'm at the lateral basal part of the right lung.
You have enough views of that, don't you?
Yeah, so probably. Yeah, pleural effusion. Perfect. Any other opinion? Okay, so you have pleural effusion because don't confuse yourself. Like some of the beginners might say pneumothorax. Pneumothorax, you should see only A lines and you should not see anything below, any lung tissue below the air. The air is the enemy. You will not see anything if you have air, only A lines. You have a black shadow, which is a fluid. That could be pneumothorax, pleural effusion due to fluid or hemothorax. Probably you need to freeze it. Sorry. You may freeze it. Be sure that you adjust the gain and depth, and you may actually measure. Not sure why not measuring. Yeah, so you have almost 1.3 centimeters. In neonate, if anything below 0.5, that's mild, and 0.5 to 1 is moderate. More than 1 is significant effusion. So that might help you to consider the decision to tap by needle or to consider chest tube insertion. What else? Usually, if you have pleural effusion, don't assume that the lung closer to the effusion is healthy, because you can see coalescent B lines and some maybe air bronchogram. Because now we have the separation of the two layers of the pleura, and you know the lung expansion is dependent on the negative pressure of the lung. So if you have pneumothorax or pleural effusion, don't expect that you have a good lung inflation. Very good. So now I think maybe the time to move to the next station. But if you have any quick question, you can maybe ask if you like.
Are you suggesting that because there is a fluid in the pleural space and the lung below is completely looking like coils in the last image?
Yeah. So what's your question again?
In the previous one, yes. Is it the fluid here in the pleural space is causing this haziness?
Yes. Yeah, as I mentioned, you should have a negative pressure. So there are two layers of the pleura keeping the lung expanded. If you lose the negative pressure because you have anything in the pleural space, it could be fluid or could be air, then you lost the negative pressure. So the lung unexpected to be expanded. So in this situation, you need to optimize the lung, the mechanical ventilation or the setting to keep the lung expanded. But the best intervention, if the effusion is significant, you need to drain the effusion. The only exception, if you are suspecting hemorrhage or hemothorax, you should not drain that. You should consult a pediatric surgeon.
No, that's not my question. No, that's not my question. It's not about clinical management I'm asking. I'm asking about why this lung below is very opaque.
Yeah, why? That I think also I'm answered this question. It is very opaque because the lung is not inflated. You don't have aeration. Yeah, if you lost the negative pressure, so the lung should not be expanded. The lung should be more collapsed, more atelectatic, because I have the compression from the fluid and also you lost the negative pressure of the pleura. So the lung should be atelectatic below the effusion. That's why it appears opaque. Opaque because you have, and when the lung is atelectatic, you have less air and more fluid and more air bronchogram. Is it answer to your question?
Yes.
Okay. I think we have only 10 minutes maybe to get a quick break and move to the next station.
Thank you.
You can communicate by email if you have any question later. Okay, thank you.
Thank you.